So these are the ways by how this data is explained. So as I told you, 1A is the best and 3C is the least acceptable one on the basis of the class of recommendation and level of evidences. So this green color is, that means it is a best one, that is class of recommendation is 1, and the red color is class of recommendation 3. A means level of evidences A, and C means evidence that is least one. So once we understand this, it becomes easy for us to go for the next. So what are various guidelines, how the therapy should be done, and what are the evidences for the current one, and accordingly what we can go for. So this is how the lipoproteins are there. We know them as VLDL, chylomicrons, and catabolic remnants. As I told you, if you remember, we have seen yesterday, these are the remnants of chylomicron and all other. Then size wise, they are greater than 30 nanometer. Then second are the diameter is LDL of is around 20 to 22 nanometers, and HDL is having 9 to 15 minutes. See, density wise you can understand, density is low, therefore their volume is more, and low density and high density accordingly. Okay, so very low density will have higher volume, and HDL high density will have lowest volume because it is a dense. Okay, this one VLDL, LDL are potentially pro-inflammatory, or they are contributing to the maximum extent into atherosclerosis, while HDL is opposite to it. It will try to prevent LDL, VLDL to cause inflammation. And this is the mechanism, is a biochemical mechanism. We will not go for that. We have studied it, we have discussed it during pharmacology. Just you can have a view on this, a brief view, how HDL is important in this, and how it helps in excretion of this cholesterol excretion, and what are various factors which are occurring to that. Then next is the various levels, and these are risk factors. We have studied this: smoking, eating fruits and vegetables, exercise, alcohol, hypertension, diabetes, abdominal obesity, psychosocial or stress factors, as we can say, lipids, and all these now factors. So these are the risk factors, and the lipids contribute highest into it, next to smoking. Next is smoking, and then stress. These three factors contribute maximum, and if these all 9 factors are present, then people are having highest chances of having myocardial infarction. So this risk factor. Then nutritions are very important. So nutrition survey shows that the total cholesterol will be there with age adjustment, because with the age there are chances of increase in that, and this nutrition will show that so this will be changing. And nowadays, because of this dietary reasons, you will find that it is going towards comparatively higher side. Most of the people are accordingly going into it. So these are the reasons how the cholesterol are changing. Coronary heart diseases risk, which are increasing because of the LDL. So as cholesterol increases, the chances of heart attack or heart diseases increases. Therapies are there. We know there are various therapies. You have classified them very classically. We know that HMG-CoA reductase inhibitor in that, atorvastatin, fluvastatin, lovastatin, pitavastatin, pravastatin, rosuvastatin, simvastatin. These are various drugs. Then bile acid sequestrants, that is cholestyramine, then cholecalcium and cholestyramine. These are 3 are the bile acid sequestrant, or we call them as a bile salts. Cholesterol absorption inhibitor like ezetimibe, then nicotinamic acid, that is niacin, and other dietary adjuncts like soluble fibers, soya proteins, stanol ester. These are various agents which are available. This is the mechanism of action which we have seen in pharmacology, that how this HMG-CoA reductase or various agents, they are affecting the formation of cholesterol or LDL formation, and how they are helping into regulating or controlling the lipid levels. So this all mechanism we will not study again, because this all mechanism we already studied in pharmacology. So these are the various factors. These are apolipoproteins are there, apolipoprotein B, apolipoprotein C, E and B. They are contributing into this transportation from to and from the hepatocytes, and on that basis the cholesterol synthesis takes place, and it will cause increase in the LDL synthesis. So these are important, and this reduction in the hepatic cholesterol synthesis will lower intracellular cholesterol, that will stimulate the upregulation of LDL receptor, and it will increase the uptake of non-HDL particle from the systemic circulation, and because of that this HMG-CoA reductase will be reducing the activity. Now this is a very good information, that if the dose is increased, how much it causes change. So each doubling of the statin dose produces approximate 6% reduction in the LDL-C level. Okay, so this is how the calculation is there. So lovastatin is taken from 20 to 80 gram, pravastatin 20 to 40, simvastatin 20 to 80, fluvastatin 20 to 80, atorvastatin 10 to 80, and rosuvastatin 10 to 20, pravastatin 1 to 4. So these are various doses, and accordingly this shows how the effect is there. That means increase in dose causes approximately 6% reduction. So suppose 10 is causing 10% reduction, then again in 10 there will be 6% reduction when it will be 20. Okay, so this is how these are working. How this shows study example is this. Suppose atorvastatin 10 milligram has caused a reduction, or bringing it to 69, reduction in 69%, then in that 20 it will be 80%, then in 40 milligram it will be 91%, and at 80 mg it will be 102%. So like that there will be decrease in the LDL levels because of this statins. So this is very important. Accordingly we can plan about drug treatments, any drug which is good, accordingly in the given condition we can think about. So there are various trials were there, and these are trial it started from 94, 95, 96, 98, 98, 2001, 2002, and up to 2003 there are various trials, and they have got various names. These are short forms are there, ALERT, then ASCOT, LLA, PRO, A to Z, TNT, Ideal, Jupiter, Research, Search. These are actually name of the trials on the basis of their abbreviation it is there. So these are various trials which have shown various effects, and on that basis of these effects the recommendations are given. So what this shows, the first one is West Scotland Coronary Prevention Study, that is WASCOPS. It's around 6,500 men were there, and it was found that the rate of myocardial infarction, or the death because of these coronary artery problems, was reduced to 5.5%, which than comparative to 7.5%. So it was very good. That is 2.5% of the people they were saved. It shows significant benefit in the people in the myocardial infarction. So these studies also shows long-term benefit those which are having cholesterol. So risk of MI or this various diseases, cardiac diseases, that has been reduced with these statins. Then it also helps in reduction. This is another study, that is Air Force Texas Coronary Atherosclerosis Prevention Study. It also shows similar results, that it provides benefit with LDL levels. Then another is ALERT LLA trial, that is antihypertensive and lipid lower. AH, anti is A, H means hypertensive, lipid lowering. So ALLHAT, heart attack trial that was found. So lipid lowering section, in that two were there, one is hypertension and another one was lipid lowering. So in that lipid lowering it was found that there was no big benefit with the statin, maybe because of there was some problem in the design of the study. It shows there was not big benefit with that. Then ASCOT shows a very big difference. It was around 36% difference is there. So atorvastatin was reducing the death with the myocardial problem or this cardiovascular diseases, that is coronary heart diseases. That was around 36% difference was there in next 3.5 years. So that is a very big one, and it was very big success. That's why these are helpful. Then various studies what they are showing, there is LDL cholesterol, how much it should be and what should be the best. So relationship between LDL-C level and event rates in the select primaries, this one. So it shows that this study will cause reduction in the death rate with various studies. What is the event rate is there. Then management of that was known as a mega trial in Japan. Management of elevated cholesterol in the primary prevention group of adults in Japanese. So here also there was a very big difference. Around 33% change was found in these persons having this myocardial problem. Then next is the HMG-CoA reductase inhibitor evidences. It was shown around 44% when rosuvastatin was used, and it shows that that was Jupiter was their justification for use of statin in prevention, and that is JUP, like that, interventional trial elevating rosuvastatin. So TER, ITER. So this is Jupiter trial. So these are not based on the name of some planet or something like that. This is how the names of clinical trials are coming. So it becomes easy to remember what was the trial. So like that, the basic name is this, justification for use, that is JU, prevention and intervention of trial revalidating rosuvastatin, that is ITR, Jupiter it becomes. So these are the trial accordingly, and it has reduced it by 44% in the 4 years. Then another was a miracle trial, myocardial ischemia reduction with aggressive cholesterol lowering, and it was found that there was quite good difference. Particularly that difference start appearing after few weeks of the treatment, and intensive statin therapy provides significant cardiovascular benefit. This was proved. Then pravastatin or atorvastatin evaluation, that is known as a PROVE. Either pravastatin should be there or atorvastatin should be given, and that was known as a TIMI study, that is infection also was checked, and comparatively to pravastatin, atorvastatin was found to be better because it has reduced the MI. Okay, here because on y-axis it is how much MI was there or cardiac deaths were there. So pravastatin was better than no drug, and atorvastatin was found to be better when in that. The another one is placebo control, placebo versus simvastatin 20 milligram days, and simvastatin 40 to 80. So either placebo or simvastatin very low dose, and as compared to that simvastatin 40 or 80 milligram, and it was found that it was benefit, and the small dose does not provide much benefit. Then SCSS, that is Canadian simvastatin survival study, that is 4S study, and here also it was proven that around 30% reduction in the rate of this cardiovascular problem was there. Then HMG-CoA reductase inhibitor evidence, secondary prevention, that is there was study, that is CARE study, cholesterol and recurrent events, that was shown around 24%. This one. Then long-term intervention with pravastatin in ischemic disease, that is called as a lipid study, long-term. Then intervention pravastatin ischemic disease, so LIPID. So this also shows 24% reduction in this coronary heart diseases. So that was a good sign as compared to, and very big number of patients were there, around 9-10,000 patients were there. So these are what we, when you see that the number of patients in most of the cases they are very high, 9,000, 10,000. So that data becomes very, very trustworthy because it has been taken and it is randomized clinical trial. We call it as RCTs, and that is what the level of evidences is. So as per that level of evidences, the maximum patients are there. The study was well designed. Very high number of patients are there. Parameters are nicely observed. So that becomes level of evidence 1, and it shows clearly benefit. There is a 24% reduction in the death rate. That means that it is very, very good, very helpful. Then HMG-CoA reductase inhibitor evidence, secondary prevention, that is LDL, statin, placebo, etc. When we consider that, and it can be found that statin helps in many people, and it shows protection. There is a significant benefit in the cardiovascular outcomes. HMG-CoA reductase inhibitor evidence shows this pravastatin in elderly people at risk. Here also statin provides cardiovascular benefit in the older men because it was only in elder studies. Then the treating new targets, that is TNT trial, when 10,000 patients were there with stable coronary heart diseases and randomized to atorvastatin or atorvastatin, and it was found that atorvastatin 80 milligram was comparatively better in results. There was 22% reduction in the major cardiovascular event, like either hospitalization or serious case or death. So it has reduced by 22%. So high dose was beneficial. Then incremental decrease in the endpoints through aggressive lipid lowering. Again here simvastatin 20 milligram versus atorvastatin 80 milligram was found that atorvastatin is having better protection comparatively in 5 years of the study. Then relationship between LDL levels and event rates in the secondary prevention statin trials of the patient with stable coronary. So these are various trials and what they are indicating, what they are suggesting. Then various HMG-CoA reductase inhibitor evidences showing secondary prevention, that is already there was once or other attack was there, either angina or ischemic attack was there, and then if we are giving it, then what will be there. So after MI it does not provide much cardiovascular benefit once it is there, but still it has to be high dose is not provide much benefit, but yes, the moderate dose shall be continued to as a prophylactic to prevent the further attacks in the patients, because it is very, very important. So this is how these guidelines are getting evolved. That means what dose we can use, when we can use, if it is angina case and if hyperlipidemia is there and no other cardiovascular problem has so far occurred, then immediately try to control it with that. That is the situation. The meta-analysis of randomized controlled trials comparing risk reduction between this primary end and secondary prevention patients. So this is how we are calculating, that is what is RRR, we have relative risk reduction. So how much it is there in CHD events, major cardiovascular events, non-fatal myocardial or after percutaneous intervention or CABG, that is, or angioplasty or CABG. These were the treatments we have seen earlier in myocardial infarction, that we want to go for PCI, that is angioplasty or CABG. So in that cases what it will be there. So how much risk reduction it will be reducing if we give these lipid lowering agents. So this is the table that is showing that relative risk reduction is quite high, that is 29 to 20%, absolutely in 1.6%, and secondary 2.4% in major one, and number which are needed to treat, around 60% are needed to treat in primary, and this one 30%, or this number of patients which were there, 60 patients or 33 patients they are needed to treat. So this is various trials, they are comparing the risk reduction between primary and secondary prevention patients and how it was beneficial. So these are various again trials, and what it shows, that various durations are there. The first two are for 2 years, then TNT IDLR for 5 years. The LDL reduction, it has caused 33%, 14%, 24%, then 23%, like that. There is a reduction in the primary endpoint, that is any chances of cardiovascular event is there. It has reduced by 16%, then 11%, 22%. You can see the very good rate is there, and the relative rates in the MI or CHD death, they have reduced by 16%. So these are how it is benefit: 16, 15, 21, 11. So these are the reduction this treatment has caused. Then next is CTT collaboration, that is cholesterol treatment trialist collaboration, and the meta-analysis of 1,69 around 1,70,000 patients, randomized at least 2 years of statin therapy. And what it was found, that it is a proportionate reduction in the cardiovascular events with greater LDL cholesterol. Just a minute. Sorry, there was one call. So this is how this intensive therapy that is helping, how this causes changes, how it causes reduction in the relative risk reduction when we start statin. So control shows around 20% death, and with statins or more statins, so aggressive statin, you can see the arrow level, and this is causing, see, it control, it causes 21%. Then if we add when we give statin, and if we add more statin, then still it go on increasing. So there is a proportionate reduction in the cardiovascular events with the greater LDL cholesterol reduction, and this shows how the high dose or how increasing the dose can beneficial in the 5 years of the study. This is very important study which shows benefits in the patients. Then next in this is the effects are there, adverse effects. There are will not go for more adverse effects or only thing, because already we have seen them as a part of pharmacology. But there are 1.4 incidences of hepatic transaminases, that is SGOT, SGPT, or we call them as AST/ALT, dose dependent phenomenon that is usually reversible. The biggest problem is around 15% incidences of myalgias, that is muscular pain which causes damages. 0.9% of the myositis, that is inflammation of myositis, and 0.2% of rhabdomyolysis, that is damage of muscles, which can be very severe one and debilitating one. These are the major side effects these are causing, but if we compare with the benefit, that is it protects from the death. So therefore risk benefit is, or means benefits are comparatively more than risk. What are the risk factors for development of myopathy? If people are simultaneously using fibrates, nicotinic acids, cyclosporine, antifungal azoles, macrolide antibiotics, HIV protease inhibitors, then nefazodone, verapamil, amiodarone, these all are responsible for this myopathy, and if simultaneously use is going on, then it will cause. So this combination of fibrate and statin should be very carefully given, or if that, then patient should be observed continuously. With nicotinic acid, it is not that big situation is there, and it is in more in the advanced age, which are having greater than 80 years of age. In women it is more particularly at older age, smaller body frame, then multi-system disease is there, multiple medications they are going on. Because of that, we have seen some of the medications. Then perioperative period, alcohol abuse, more alcohol, grapefruit juice more than 1 quarter per day. So these are causing, because grapefruit juice can also be converted into alcohol like situation, and therefore. Then other drugs are bile acid sequestrants. We know how they are reducing the reabsorption of acid. These bile acids will cause decrease in the binding, because they are emulsifiers, and because of that it will reduce cholesterol absorption or lipid absorption, and thus that will help in the excretion of LDL. So these are what benefit it is causing. Now what are their evidences, what are the effects they are causing? They can cause the decrease by around 15% decrease in the LDL-C around 3% increase in the HDLC, and it can cause increase in around 10% in this is with the cholesterol. Then the cholestyramine, we can see that there is 19% relative risk reduction when it is given in the hypercholesteremia, so that is also beneficial one, good benefits is occurring. Then another drug is there which is affecting or which is decreasing the absorption from intestine is acetylcholine. So this drug will be not allowing, and it will be excreted in feces, that is fecal sterols, and neutral sterols will be increasing. So what it causes is, it causes a decrease in around 16 or 17% approximately decrease in LDL, that is good sign. Around 1.3% HDL it will be making, and the thing is it is reducing triglyceride. It is again beneficial effect as compared to this one. So it can reduce both LDL-C and triglycerides at the dose of 10 milligram. This is quite beneficial, and therefore it can help many times. Dietary adjuncts which are evidence at the reducing LDL. So if we give some dietary soluble fibers, there are many examples. Psyllium seeds, isabgol seeds, like they can reduce LDL-C by 10 to 15%. Soya protein can make it 5 to 7%, and stanolestor they can do it around 15 to 20%. So they are also very good way of reducing the lipids. Then this coronary heart disease risk according to HDL-C level. So HDL, we have seen that it should be this ratio, it should be 40% minimum. 40 milligram it should be in male and 50 in female. So if it goes down, if it is suppose 65, then the risk is minimum 1, and if it comes down after 45, then it doubles to 2, and if it is going far lesser to 25, then it becomes 4 times more, that is 4% or in that people. So this was Framingham study. This Framingham study said that how HDL is important. How this is helpful, because HDL is nicotinic acid is the next drug. This nicotinic acid is responsible for mobilization of free fatty acids, and this causes the mobilization of these agents from systemic circulation to hepatocytes, and from that VLDL is going, and there is a decrease in the serum LDL. Serum VLDL also decrease, and therefore it causes increase in HDL. So these are various action it is showing, because it is affecting triglycerides synthesis and decrease in the VLDL secretion. So what are the benefits it is showing? If the dose is 500 milligram, no big effect is there, but if dose increases to 1000 milligram per day, then there is a 9% decrease in LDL-C and 11% in triglyceride. Here again, unique thing is comparatively it is more active in triglycerides, or it causes more decrease in the level of triglycerides as compared to this one, and simultaneously it can slightly increase HDL-C as it decreases LDL-C and triglyceride. It also increases the very good graph. It shows all the activity in one go, that at dose 1000, what it is making at dose 1500 gram, it shows 14% reduction in LDL-C and 28% reduction in triglycerides and 22% increase in HDL-C. So this is how it is very clear data. It shows niacin, and it is the most effective medication for increasing the level of HDL-C. This is very important for HDL-C. It also lowers LDL-C and triglycerides, and comparatively it is got comparatively more effective in triglycerides reduction. Then if we go for these activities, we can see that niacin provides a long-term beneficial after myocardial infarction. It can be given into that, and it helps in reduction in the rate of this myocardial disease, or it improves the survival of the people for not beyond 6 years, 7 years. So this is how it is helpful. Then in secondary prevention, uh, it uh, it gives along with some other drug, statin plus niacin provides benefit to men with coronary artery diseases, and it reduces the low LDL or those which are having low HDL-C levels. In that it is beneficial, it is helping it much. Then antithrombosis intervention in these people, that is metabolic syndrome with low LDL, high triglycerides, and impact of the global health outcomes. So what it shows is there is no big differences, no benefit to those with cardiovascular disease and low LDL-C. So already in one study it shows that it was not beneficial, while this other study shows it was highly beneficial. Again, there was no benefit with those with cardiovascular disease and low HDL levels. Cholesterol ester transfer protein evidences, these are drugs which are causing the ester transfer protein, and these are also found to be beneficial. These are the mechanism of action, how these are acting. So this study shows the drug is torcetrapib. Okay, when we combine it with atorvastatin, it shows comparatively slightly better or slightly beneficial effect in the reduction, that is cholesterol ester transfer protein inhibitor, that is torcetrapib. Is this is a new drug, very recent drug, and the trial shows benefit when it is combined with the atorvastatin. So there is other drug, that is dalcetrapib, and again no big benefits are there. Sorry, here I'm sorry, this torce is associated with increase in the cardiovascular risk. I'm sorry. So this causes slightly increase in the cardiovascular risk, that is torcetrapib, and therefore it is not beneficial. Then this has got again no benefit, almost equal graph you can see, and elevated triglyceride level is associated with increase in the cardiovascular risk in these patients. Then lastly, fibrates mechanism, you know, I will not repeat it, that is how these fibrates are working, how they are reducing the VLDL formation, and they decrease the triglycerides, and they are acting at various levels. Because of that, they increase the HDL level, and they stabilize the macrophages. So by that virtue of action, on the basis of these actions, what are they doing? They can cause decrease in the LDL by around 20%, increase in HDL by around 11% at 100 mg 3 times a day dose if it is given. Then triglyceride they can reduce by 38%. Again, these are very good agents which can reduce triglycerides. And those which are having type 2b type hyperlipidemia, where triglycerides are comparatively more, so it causes up to 45% reduction in weight and 15% increase in HDL. So this is again very beneficial study, very important study which shows changes. Then fibrate evidences, primary and secondary preventions. If we plot the graph versus primary and secondary interventions, so we can see that what happens with this when comparedly, we can see that there is a reduction in the rate, several around 9%, 42%, 22% in secondary prevention, and it is quite big, it is very good one. In similarly, it is also in primary, how it is fibrate when it is added, it causes primary as well as secondary prevention. Primary means before any heart attack or this one, when we find that lipid level were high and it can cause harm, then it is a primary protection, so that we are avoiding, we are not allowing patient to have myocardial infarction or cardiovascular disease. This is primary prevention. Secondary means already one attack was there or one cardiovascular event was there, and after that we want to prevent the subsequent one, so we'll call it as a secondary prevention. So in both cases it is beneficial, it is reducing the chances of it. Then fibrate does not provide significant additional benefit in diabetes. If it is given in the diabetic people, then there is almost same changes are there. There is no big benefit it is occurring. Then on background of statins therapy, fibrates does not reduce cardiovascular events in the diabetic as compared to this one. So what is the effect now? Let us make a final total or sum totally. So statin in a standard dose, all this can reduce triglyceride by 19 or 20, around 20%, LDL-C around 25%, HDL increase by around 4%, 4 to 12%, triglyceride reduction is around minus 14 to 29%, patient tolerability is good. Is a time we again can cause 13% reduction in this. LDL-C reduction is around 18%, HDL can increase by 1%, triglyceride reduction by 9%, and patient can tolerate, very good tolerate. Bile acid sequestrant patient tolerability is less. There are no big changes in the triglyceride, but they can reduce good amount of lipid LDL-C. Nicotinic acid is very good for triglyceride. You can see that it can do it around minus 30 to 70%, but patient tolerability is comparatively poor. It has got more adverse effects. Fibrate can also do around minus 30% reduction in triglyceride, and they have comparatively less effect in. This is only what I asked you yesterday. This was my homework which I have given you, that which drug can be effective in triglyceridemia, which can be useful in the increasing the levels of HDL, and which are the drug which can be useful if we have to reduce total cholesterol or LDL-C. So this one table is giving all the information which I asked you yesterday. So then next is omega-3 fatty acid, we shall see in next class. I hope you are understanding. These are all evidences, and accordingly we can plan the treatment when these people are coming. So here we finish.